Hi, everybody. Thank you very much for joining us here on Newsworthy. You're possibly seeing us on YouTube or our Facebook channel. My name is Anubha Bhonsle, and the focus of today's conversation is essentially on drugs and therapies that have become part of our everyday life, everyday vocabulary, everyday conversations. So whether it's plasma therapy, remdesivir, ivermectin, or steroids, we're all constantly talking about it. Well, many of you watching this particular telecast would have either used one of these medicines or are still using. Some of you would have scrambled to get your hands on one of them. Some of you may perhaps still be scrambling. And there could be many among you who did feel better after taking one or possibly all of these remedies, and many others for whom it didn't work. Add to that a layer of mixed messaging, treatment protocols, and guidelines that are being changed. So all of this is leading to a whole host of anxiety, a lot of information, a lot of misinformation, and a lot of information overload, if I can call it that. So the aim of this conversation is to take you through the entire gamut of therapies and drugs and tell you what works and what doesn't. I am very, very fortunate to be joined this evening by Dr. Priya Sampathkumar. She's an infectious diseases expert. She's the chair of the Infection Prevention Center and Control at the Mayo Clinic. And she's been very, very kind enough to join us for the second time. We had a bit of a technical blooper. So Dr. Priya, I really appreciate this. Thank you for your time. It's a good evening from all of us here and a good morning to you, of course.
Thank you. Thank you for having me on.
Dr. Priya, before we sort of dig in, I think it would be good for us to put out a caveat or a disclaimer for anyone who's listening, since we're going to talk about drugs and therapies that people are using or may want to use.
Yeah, I think it's good for all your viewers to understand that what we're talking is general recommendations about medications, and that all of these medications for COVID should ideally be used under medical supervision. So your doctor should prescribe them, and the doctor should understand what your own personal health history is and how these medications might interact with other meds you're already taking. So these are general recommendations. These are not to be taken as medical advice per se.
So the idea is to sort of, equip you with all information about guidelines, about how to interpret them. As I said, I'll go one by one. Dr. Priya, while scoping out this interview, was of the view that we should focus a lot on drugs and therapies that work and not so much on those that don't. But oddly, a whole lot of questions that have come from many of you are about drugs and therapies that don't quite work. I'm going to start with the first one, and that's plasma therapy. Dr. Priya, as we know, the ICMR has dropped plasma therapy from the recommended treatment guidelines. And I think it knew it early, sometime in September of last year, that plasma therapy, in a sense, would not reduce mortality outcomes, nor could it stop disease progression. I think my first question to you is that why do you think we waited till May 2021 to drop it from our guidelines? And apart from the scramble and the pain that people have gone through to try and get a plasma donor, what do you believe has been the impact of this usage over the last 6-7 months?
So I can't, really comment on the workings of the ICMR. I'm not sure what they were thinking. Their recommendations were actually not bad. They did say that plasma, if it's used at all, should be used early on in the infection, that plasma therapy in late stages does not work. Unfortunately, that message kind of was too nuanced for the public. They just saw plasma appears on the guidelines. And I think that doctors throughout India also kind of had this misconception that plasma can be life-saving and were recommending it to patients. And then there was a lot of hype around, celebrities donating plasma. Someone who's recovered from COVID, they want to do something to contribute, so they were eager to donate plasma. And people were eager to collect that plasma, and there was this misconception that it's life-saving. So it was really heartbreaking over the last several days to see these frantic messages on Facebook, on Twitter. My brother is in the ICU, desperately seeking 2 units of O-positive plasma, etc. So definitely the data is very clear that in severe disease, it's too late for plasma to have any role at all, and you shouldn't be seeking it out. Now, in addition to the heartbreak that individuals who have not been able to find plasma for their loved ones are going through, there's also another consequence to this, this race for getting plasma, convalescent plasma for treatment of COVID, and that is the enormous strain on blood banks. So blood banks collect a lot of other blood products, and this collection of plasma for COVID has strained them to the point where many blood banks in many parts of the country are running very, very low on blood, which is absolutely life-saving. If you have bleeding from anywhere, if you have a GI bleed, or if you are in a road traffic accident, blood is life-saving. The other thing that they're also running very low on is platelets, which are these clotting cells, which are also collected from blood donors and help in patients with low platelet counts to prevent bleeding or treat bleeding. So in addition to plasma being collected, not being helpful for COVID, the other downside is that blood banks haven't been able to collect these other life-saving measures.
Dr. Priya, the AIMS and the ICMR National Task Force has actually concluded that the plasma therapy doesn't work, but I'm wondering why an official decision is not binding on sort of individual health practitioners. I mean, why would some doctors continue to sort of prescribe plasma therapy? What are the scenarios in which they would continue to prescribe it?
So in the current setting, really, there should be no scenario where plasma is prescribed at all. Just because patients are coming in fairly sick, plasma is given in the hospital, and patients, by the time they arrive in the hospital with COVID, are beyond the point where plasma could be of any help. So there's really no indication for plasma at all in the current situation in India. Guidelines are... I'm sorry?
As crystal clear as that?
Yes. So, to answer your question about why guidelines are not binding, the reason is these are guidelines. These are supposed to guide doctors. They're not mandates. They're not edicts. The guidelines put out by ICMR are supposed to be science-based. They tell doctors what drugs work and what don't work. But any physician in India, and anywhere in the world actually, can prescribe what they think is right for their patient. And I hope that doctors will pay attention and use evidence-based medicine, but guidelines by themselves can do it. And I think that news media can actually play a very important role in getting the word out to the general public. If they don't seek out plasma, or if they, when their doctors say, I need 2 units of plasma, they could say, but it doesn't really work, and why are you asking me to get plasma?
You may have heard of reports, Dr. Priya, here from India. Many times doctors said that they were pressurized by families of patients and caved in, so to speak. This isn't sort of a moral judgment of any kind, but I'm just wondering, how does that sound medically?
I have not practiced medicine in India for a few years. When I last practiced in India, it was kind of a completely opposite situation. Patients were not really involved in decision-making. They always said, whatever you say, we'll do. And I understand that things have changed a little bit, but again, the doctors, should be able to say this does not work, and here are the other things that work, and should be able to talk patients out of unnecessary therapies. Collecting plasma is expensive. Collecting plasma and giving plasma does have a few risks. So I don't think anybody would want their loved one to get plasma if it was made very clear to them that there's no benefit at all and that there is a small risk associated with the treatment.
Okay, so sort of in brief, in conclusion, I want to wrap up the conversation on plasma. What would you say to anyone who has either recovered or seen a loved one recovered from plasma or is considering plasma this evening?
That if you've recovered from plasma from COVID, you do not need to donate your plasma, and that if you have somebody who is in the hospital with COVID right now, plasma is not a useful therapy in the Indian situation. Okay. Now, I also want to add that the plasma as a treatment, came about early during the course of the pandemic when we had no other therapies, and there was a lot of hope for plasma. And this is why we do clinical trials. I mean, theoretically, it makes sense that plasma would work. You're giving antibodies to patients who don't have any. So theoretically, it should work. And that's why we need trials to see in real life, does it really work? And now there have been several large trials that have shown that in severe disease, it does not work at all. There may be a role in very mild disease early on, but again, that role is so small in the current Indian context with cases rising so rapidly. Focusing on something that may have very minimal benefit is no good to anyone.
No good, not treated. Okay, I want to move on to the next one, and that's ivermectin. The manufacturer, World Health Organization, all are sort of warning against the overuse of ivermectin and saying there's sort of no data to prove it prevents or helps treat COVID-19. But here in India, it's a state protocol in at least 3 states. There is a blanket prescription for preventing COVID-19 and using ivermectin in Goa and Uttarakhand. In Tamil Nadu, I believe all COVID-19 patients, irrespective of symptoms, are going to be prescribed this. ICMR has also included it as a may do. And I think sort of the crux of it is that unlike plasma, about which doctors were sort of divided even here in India and abroad, as far as ivermectin is concerned, you're finding really all doctors across the board, and I'm using that term loosely, but roughly all doctors or a good majority are prescribing it very, very soon after someone tests positive.
So this is just inexplicable to me. I'm quite active on Twitter, and this is the thing that I get trolled for a lot. Speaking up against ivermectin, I don't know why it has people so energized and why there's so much conviction that it works. There have been no clinical trials that have shown that it works. There have been a number of clinical trials that show it doesn't work. So at this stage, and what ivermectin is really a anti-parasitic drug. It's been around for a very long time. It's very effective at treating some things like scabies, like treating a condition called river blindness in Africa. It is not an antiviral. There is no reason to think it would work in COVID. When, again, during the early part of the pandemic, there was a lot of interest in repurposing existing drugs to treat COVID. And this was one of those drugs that people started looking at. And again, early on, it was reasonable to look at it and to trial it. But at this point, there's no evidence that it works. So I find it really inexplicable that Goa would say everybody will use ivermectin for prophylaxis. So that does seem way over the top. Now, there are side effects to these medications, and when you give a few patients medications, and if they have a condition like scabies that warrants medication, those side effects can be managed. When you give a medication on a population level, thousands and thousands of people, and in India, it could be millions of people, you will definitely have adverse outcomes that are simply not worth it because it wasn't doing you any good at all. So I would definitely say this is a bad idea. And I want to say one thing about Tamil Nadu. Tamil Nadu is one of the states that dropped ivermectin from its guidelines. So I'm very proud. This is my home state, and I'm very proud they made this decision.
Again, what would you say to someone, Dr. Priya, who has recovered or felt better after taking ivermectin? I mean, I'm sure we don't know, and you're speaking to someone like that, who felt better after they took ivermectin after being infected with COVID-19. I mean, how do people wrap their heads around sort of this dichotomy?
So the one thing to keep in mind is that 90% of people who get COVID will recover, regardless of whether you take anything or not. So if 100% of people got COVID and they all took 100% of people who got COVID took ivermectin, 90% of them are going to feel better because of the natural history of the disease. So assuming that it was the ivermectin that made them feel better is kind of fallacious and a wrong conclusion.
I'm not sure if you've seen it, but there are sort of doctors and outfits putting out public service announcements calling for ivermectin to be a part of home care. How scary does that sound to you?
I think it's completely, it has absolutely no basis in science. And yes, it's oral. People are attracted to the fact that it's something that's oral, therefore can be taken at home. And again, in the grand scheme of things, on an individual basis, if you took 3 days of ivermectin or 5 days of ivermectin, it probably wouldn't do you too much harm. But when you give it to millions of people, there will definitely be adverse outcomes, primarily liver toxicity from these doses of ivermectin. So I would say it's a very bad idea.
Bad idea. Okay. To the third one, and I'm going to refrain from sort of listing out the many studies that at best have found remdesivir to be modestly reducing the time to recover from COVID-19 in hospitalized patients that may have had severe illness. But as you know, in India, this drug has been a source of stampedes. It's been a source of anxiousness and possibly more infection. Do you want to clarify, does that work or not?
So remdesivir is an antiviral. Again, there was a lot of hope for this drug when COVID began. It was very active against the SARS-CoV-2 virus in the lab. So large studies were done, and we were all very hopeful that this would be a game changer. Unfortunately, like many other things with COVID, that's not how it panned out. There was no mortality benefit from remdesivir. So people's risk of dying from COVID did not change whether they got remdesivir or didn't get remdesivir. So, of course, remdesivir is a really expensive drug, and there is a lot of interest in trying to find an indication for an expensive drug, because that's what makes drug companies money. So then they continued to analyze the data, and they said, well, in some patients, it does reduce the duration of hospitalization. So remember, all these studies of remdesivir were conducted early on in the pandemic, where we kept patients, everybody with COVID, in the hospital for a long time because we didn't understand the natural history of the disease. We were afraid of complications. So use of remdesivir cut the hospitalization rate from 15 days to 10 days. So there was a significant decrease in hospitalization rate. But nobody at the current time is staying in the hospital for 15 days at all. So it really is unnecessary to get remdesivir. The other point is that the way remdesivir was used in the trials was early on in the disease, before the patient became very sick. And how it's being used in India is in the hospital, in patients on ventilators, in patients with advanced disease. Again, that does not make sense. And because it's such an expensive drug, does have side effects, and because the shortages are causing a near stampede situation in pharmacies, I completely agree with you that this is another drug that we should be very clear about and say, you should not have to go look for it, and you should not make any special efforts to find it.
It is actually still part of ICMR's guidelines, Dr. Priya, as something that can be considered in certain cases. In fact, there have been statements from the likes of the AIMS director along the lines that we may use it because we don't have an antiviral drug. Part of the problem is mixed messaging. Part of the problem is that this may be messaging that's not directed to the population at large. But this is a pandemic where everyone is trying to find out as much information as they can about every drug. Is there a need to sort of fine-tune the remdesivir communication, or do you believe it is clear?
I think that I think you could be clearer about it. So I haven't looked at the ICMR recommendation in a few days, and it keeps changing. But the last time that they had it, I think they had reasonable parameters for use of remdesivir. It was early on in the disease, mild to moderate disease. Again, all those nuances get lost. People just see remdesivir on the guideline and then they run with it. So again, clearer messaging would be very helpful. From the ICMR, I don't know how, all the doctors in India are right now so extremely busy with managing COVID. I don't know if any messaging will even get to them at this point. But again, these are things that should have happened in between surges, talking about the science and putting the word out.
I promise that this is the last one about drugs that have a question mark, and it's Fabiflu. I'm not sure if I'm pronouncing the original name right as Fabipiravir, but sort of how the drug is ineffective even in the lab has been clear. Glenmark's own trials are there for everyone to read. And the ICMR also had it in its initial treatment protocol. They've now removed it. Doctors are actually still prescribing it. It's an expensive drug. The full dose is a really expensive one. Why is it prescribed when we don't have data to sort of offset the benefit versus risk kind of a thing?
So Fabiflu or Favipiravir is also an antiviral agent, but it's an antiviral agent that's directed against influenza. It really does not work against COVID. And because it was an oral agent, it was, again, a lot of hope that if an antiviral that can be given orally works, you could prevent hospitalizations. And that did not pan out. There are studies that clearly show that it does not work at all in hospitalized patients. Again, let's step back and just talk about the natural history of COVID. So when you're exposed to COVID, the virus starts multiplying in your respiratory tract, and that replication goes on for 7 to 10 days before the body's immune system takes over and starts fighting the virus. So any antiviral agents, to be useful, need to be given in that early part of the disease. And most of the time until day 4 or 5, you have no symptoms, so you don't even know you have it. And then for the next 2 to 4 days is where you have mild symptoms and you have COVID and the virus is still multiplying. So anything that you give as an antiviral, that's the time to give it. So if you were going to give remdesivir, that would be the point in time to get remdesivir. Beyond that, when you start having low oxygen levels in the blood, that is a result of the inflammation in your lungs from the body's immune system attacking the virus. So anything that you give at that point should be drugs that work on the immune system, not drugs that work on the virus. So that's why giving plasma, giving any kind of antiviral at that point in time, when you're hospitalized with COVID, is not helpful at all. So the same thing holds for Fabiflu. It does not work at all. It doesn't work against the virus very well in the first place, and definitely doesn't work in the hospitalized patient. There are studies ongoing in different parts of the world looking at it at treatment for very early disease. So far, there has not been any proof that it works, though.
I'm sure, we could have done things very differently, but I'm wondering, in the trajectory of this pandemic, if you start from last year, every drug that has sort of come into spotlight that people have scrambled for has sort of died its natural death. We saw it with HCQ and plasma, Remdesivir, Ivermectin. They've sort of been there, everyone scrambled for them, and as more details or more guidelines have come, they've slowly slipped away. Do you think this was this was expected?
Yes, exactly. That's how science works. We have ideas about how things might work, and then we try to prove whether they work or don't work in clinical trials. So the fact that, as scientists, we told you a year ago to take certain medications, we're not just changing our mind because we are changing our minds. We're changing our minds and giving you a different message now because we have data that suggests that certain things don't work. So that's a really important thing for your viewers to note. Early on, whenever there's a new, this was a brand new infection that caught us all off guard. So we tried a lot of things, and as data comes out about these things, we do need to change our minds and move forward with better advice.
Okay, so I think it's the perfect point for you to tell us the drugs and treatments you believe would help people in combating COVID-19.
So first of all, the key thing to remember is that most people with COVID will recover fully with no need for hospitalization, no need for any additional treatment. If you have mild COVID and you're at home, you do need to isolate yourself to keep from transmitting to other people. You can take things like paracetamol for your symptoms, body aches, headache, etc. Otherwise, no treatment is necessary. As far as preventing progression to a more serious disease, there's nothing that works really well. There are some steroid inhalers that in very small studies have shown to decrease the risk of hospitalization. And if you're over the age of 50 and have other comorbidities, you're severely obese, or you have hypertension or diabetes, these might be a reasonable option. They are apparently in very short supply. So if you can find it, I still wouldn't worry about it because the benefit they give you is very marginal. Now, if you, the most important thing in patients with COVID is for them to monitor themselves, make sure they're not becoming short of breath, and ideally, if they can, check their oxygen saturation with a pulse oximeter. And about 92% seems to be the level at which we start to worry about lung involvement and need for hospitalization. So if you are at 92%, you should seek medical care because you need oxygen at that point in time. I know that in many parts of the country, hospital beds are really, really hard to come by. So while you're waiting for to get the hospital bed, something that's very simple that everybody can do is for the patient with COVID to lie on their stomach. Just that simple positioning can increase the amount of air that goes into the back part of the lungs and increase oxygen levels. And then if, despite that, oxygen levels haven't come up, you definitely need supplemental oxygen. Supplemental oxygen is life-saving. And typically it's administered in hospitals. Nowadays, a lot of people have oxygen concentrators at home. And there's a very, very short supply of these oxygen concentrators, oxygen cylinders. So if you have one, please share with other people if you're just holding on to it because you may get sick. There are people who are sick right now and can't access oxygen. So having a lending library kind of function would be really, really helpful. And then at the point where you do need oxygen, the other medication that is life-saving is steroids. The typical steroid we use is something called dexamethasone. There are a lot of equivalents of that you can look up in various sources, but it's a small dose of dexamethasone given for 5 days. And again, that can be life-saving. Now, a small number of patients will progress despite this and may need to be in the hospital and get what's called non-invasive ventilation, which is a tight-fitting mask that pushes oxygen into your lungs. Or even if they get even worse, may need to be intubated and put on a ventilator. But these are the standard treatments. The other treatment that isn't directly against COVID is blood thinner medication. So COVID increases the risk of blood clots. And when you're very sick with COVID, you're not walking around as much. And that also increases the risk of blood clots. So blood thinner medication, until you become more mobile, can also be life-saving.
So you've listed out 3, Dr. Priya: supplemental oxygen if you need it, steroids, and the last one, right? I mean, those are the
blood thinners.
Blood thinners, sorry. Those are the 3 ones that you're putting in the drugs that work or could be life-saving.
And I want to make one more point about the steroids. So steroids work, as I said, early part of the disease, the virus is multiplying. The later part of the disease is when the immune system is kicking in. So the steroids work only in that later part of the disease where you have low oxygen levels. Because they work in that time period, you should not be taking steroids earlier. If you take them when you're at home and asymptomatic, that can actually do a lot of harm because steroids will promote viral replication and you'll have a higher viral load and potentially more damage if you take it at the wrong stage of the disease.
You've possibly already heard reports of sort of steroids being overprescribed in India. We have now reports of black fungus cases increasing. In fact, the center telling many states that they need to call it an epidemic. Can you sort of just delve deeper and explain sort of this linkage between the steroid overuse and black fungus?
So what's called black fungus is an infection caused by a group of fungi that are present in the air all around us. And they're actually present in very high quantities in warm climates. So places like India have a high background rate of this fungus in the air and also have high rates of infection with this fungus. Typically, outside of COVID, this infection happens in people who have uncontrolled blood sugars. As you know, diabetes is very, very prevalent in India. And when blood sugars are not controlled, the fungus it gives the fungus a natural edge and it causes disease. And the two most common forms are infection in the lungs or infection in the sinuses. Now, in COVID, some of the other things that promote this infection are use of steroids. Now, steroids directly suppress the immune system, so they make you more susceptible to this infection. The other thing that steroids do is actually increase your blood sugar. So if you have a tendency towards diabetes, you may have normal blood sugars, but once you get steroids, that makes your blood sugars go out of control. So it's very important that you use steroids correctly and that when you're using steroids, you actually check patients' blood sugars and control the blood sugars with insulin as needed when they're hospitalized. The other things that can promote the black fungus is overuse of antifungals that are not active against it. So people have been giving prophylactic antifungals in the hospital, an agent called voriconazole. Again, it's oral, it's easy to give. They've been giving it. This has no activity against the mucor, which is the agent that causes the black fungus infections. So again, it's allowing that to overgrow. And similarly, antibiotics can also have the same effect. So all of these factors are just coming together and causing overgrowth of this fungus. So the most, yeah.
Sorry to interrupt. I mean, I was essentially sort of trying to sort of stitch this entire conversation together because, you know, what's happening, Dr. Priya, is that while people are getting treated for COVID-19, and someone joked about it, they're also getting treated for zinc deficiency, vitamin C deficiency, vitamin D deficiency, a whole lot of antibiotics. You know, this is sort of a time where there's an over medication on every quarter, really, for every citizen who of course does have access to doctors and medical supplies, etc.
Yes, exactly. So there are something like 15 different things you are getting treated for if you use one of the kits that have been prescribed. So influenza, scabies, vitamin deficiencies, river blindness, other types of parasitic infections, bacterial infections. And none of these really work and can do a lot of harm and give you other types of infections.
So is there anything that you'd like to say for people who may have recovered from COVID-19 but are still taking about, 8 to 10 tablets every day? There's zinc, there's vitamin D, there is turmeric, there is steam inhalation, there is everything possible.
So none of these things really work. That would be what I would say. And some of them may do harm. So really consider each one of these medications and think about whether you should be taking them or not. Amongst these medications, things like zinc and vitamin A, vitamin D probably won't do you a whole lot of harm. Many of the other things can do harm. So those would, if you want to wean yourself off these medications, those would be the ones I would start with. And then things like steam inhalation probably won't hurt you. They don't help. But if it makes you feel better, that's okay. Now,
Sorry, go ahead.
individually at home by yourself, these sort of mass steam inhalations are a really bad idea because, again, bringing people together and doing something like steam inhalation that could promote spread of infection is a bad idea.
It's a bad idea. We've seen those images and they're sort of quite a horror by themselves. We had a question that came in on one of our feeds, Dr. Priya, and it was to really do with infection and how long can you continue to be infectious if you contracted COVID-19. I know that the Indian guidelines as well as several other CDC guidelines have often indicated that if you're a good immune system, you're not going to have sort of a viable viral load that you would shed beyond 10 days. I'm just wondering in India if there is a sort of cultural context that we need to sort of factor in, or is that 10 to 12 days roughly the time band we should continue to look at?
So in the US, the CDC guidelines said 10 days is when you are considered infectious if you're healthy. And if you had either very severe disease and therefore more virus, or if you are immunosuppressed or have certain risk factors like cancer, chemotherapy, etc., we would consider you infectious for 20 days. And this time-limited duration of infection has been very helpful because actually when you do the PCR test after you're recovered from infection, sometimes people can be positive for many, many days. The longest I personally have had a patient test positive is about 185 days post-infection. So what the PCR test does is it detects presence of virus particles in your nose. These virus particles can be dead or alive. The test doesn't distinguish between those two. So having a positive test doesn't necessarily mean you're infectious, and that's why we don't recommend rechecking a test just to prove you're non-infectious. So if it's negative, great, but if you're positive, it doesn't necessarily mean that you're still positive, that you're still infectious to others. So one other thing that you can factor in, you talked about the cultural context. I think that with the second wave, a lot of people have been having symptoms for longer than usual. The first wave, it was, most people were better in 7 days. With this wave, people are having fever for longer than that. And I think if you factor in fever into the definition of infectiousness, that really helps. So what I tell people is you should quarantine for at least 14 days or until 2 days after your fever has completely resolved. So whichever is longer is where you would go. So if your fever resolved in 2 days, I don't think you can come out of isolation. But if your fever has not yet resolved at day 14, you should stay in isolation until you've been fever-free for 2 days.
Just sort of final two odd questions, Dr. Priya. I don't know if we've taken you for long, but just to wrap it up and stitch it together, whether it's drugs like Ivermectin or Remdesivir, they're obviously not the first and they're not going to be the last medication that are sort of prescribed off-label by doctors when they believe it's in the interest of the patient. I think you said it somewhere in your answer that science is obviously not going to take the shortcuts, but medical practice and doctors are working sort of in just a completely different hellhole. There's sort of odds against time, there's risk of death. It's sort of a far more grittier decision making. How do you believe you're doing a good job? And I know you're at a distance there, but do you believe we're doing a good job navigating the two?
So I think that doctors are doing their best under, like you said, unimaginable conditions. Now, when hospitals are overwhelmed, when healthcare workers are overwhelmed, outcomes are poorer than otherwise. So even under situations where COVID has a high mortality when you get hospitalized, even under the best of circumstances. And right now in India, when you get hospitalized, there are lots of issues that doctors and nurses are so stressed, they're not able to give enough time to a patient. So the most important thing that people can do is actually break that cycle of transmission, start working on lowering cases, because then when the people who are really ill go to the hospital, doctors and nurses will have more time to think about the case, give them the best possible treatment. So we talked about flattening the curve early on in the US. And that was key. So our first wave in New York, where, again, a lot of technology, a lot of resources, still the mortality was horrendous because facilities were overrun, because there were shortages of ventilators, because there was shortages of medical personnel. So for the general public, avoiding gatherings, masking, regardless of whether your state is in a lockdown or not, doing your own personal shelter in place, your own personal lockdown is going to be very, very important.
Personal lockdown. From everything, Dr. Priya, that the government puts out, its task force puts out, the ICMR puts out, the press conferences come, the guidelines, how does sort of an average citizen distinguish between what is communication for doctors and what is communication for people and an average citizen?
So I don't even know what an average citizen in India is, right? There's such a wide spectrum in education, and it's very, very hard. And this whole communication problem is not unique to India. India, it's compounded by the fact that India is so diverse and that there's so many languages, so many different cultural references that people have. But even in the United States, we failed in communicating. So early on, and despite the very high literacy levels of the US, the messaging was very unclear right from the very top. There were treatments that were not useful, that the medical community did not agree with, that were really touted as being life-saving, with hydroxychloroquine being the one case in point. So I think that really it's important that science is left to the scientists and doctors. There should not be political interference in these guidelines. We learned our lesson in the United States, and some other countries also need to take that to heart. It's medical professionals who know how to treat COVID, and they should be the ones making recommendations. And these recommendations should not be politically motivated.
As a sort of final word for our viewers before we wrap this up, is there anything you'd like to say? Because I'm sure as many are watching this, they're possibly self-diagnosing, Googling, medicating, this entire self-analysis about where you are in the COVID trajectory that may be going on as we are even sort of doing this telecast.
So my final words again would be that most cases of COVID will be mild, and I hope that each one of you will be in that category. If you do have more severe symptoms, you need to seek medical care, primarily for oxygen and steroids. No other treatment is really life-saving. Continue to keep your distance from other people, especially if you think you're infected. I know that testing is also hard to come by in many parts of the country. And in the present moment in India, if you have a fever and a cough, you have COVID unless you definitively find out you have something else. So assume you have COVID and take appropriate precautions.
Fair enough. Is there anything that I haven't asked you? I know we've not touched on the entire vaccine gamut because that sort of opens up an entire different line of questions, but is there anything that you'd like to add, depending on what you're seeing in other parts of the country or in your work in other spheres?
So I think that I'd just like to leave a last remark about vaccines. The vaccines do work. I've been hearing a lot of comments from people about, well, so-and-so got 2 doses of Covishield and now has COVID. And remember that the Covishield vaccine is only about 70% effective against infection. So a good 30 out of every 100 people who get Covishield, a good 30 of those will get COVID. The important thing is only 1 out of that 100 will actually have serious infection. And that's what the vaccine is intended to protect you against. Not just getting COVID, but getting COVID that's bad enough that you would need to be in the hospital. And the vaccine is also very, very, very effective at preventing death from COVID. So if you have a chance to get vaccinated, please go do it.
Please go do it. Okay, with that final word, we'll wrap it up. Thank you very much, Dr. Priya, for spending almost an hour plus with all of us and answering all these sort of basic and nitty-gritty questions. I hope you have a good day ahead.
Thank you.
Well, that's it here on Newsworthy. We'll continue to have these conversations. If you have a question that we still haven't answered about drugs that work or don't work, remember you can put them in the chat comments. You can put them in the comments on Facebook if you're watching it there. We have another expert and another doctor coming up tomorrow, and I'll make sure that I put all those questions to him when he joins us once again on Newsworthy. If you've been watching, thank you for your time. I'll see you again very soon.